So let me invite Dr. Litta George to present on anti-glaucoma medications and overview. Dr. Litta is the consultant glaucoma surgeon in Tony Super Specialty Eye Hospital, Aluva. Over to you, Litta.
A very good morning to all of you. So I'll be talking on anti-glaucoma medications. So as we know, glaucoma is a chronic progressive optic neuropathy. Raised intraocular pressure is the most important risk factor for glaucoma. Despite medical researchers working on various other aspects such as neuroprotection, neuroregeneration, and vasoregulation, intraocular pressure remains the only modifiable risk factor as far as glaucoma treatment is concerned. So coming to the history, pilocarpine was the first drug available to us way back in 1875. With newer and newer drugs coming into the picture, glaucoma has largely become a medical disease now, with the surgical indications coming down consistently over the years. In normal individuals, there is RGC loss by apoptosis, which is much faster in a glaucoma patient. The fundamental goal of our treatment is to reduce the cell loss to an age-dependent rate. So whatever be the spectrum of glaucoma, reducing the intraocular pressure helps in decreasing the progression of the disease. You have different modalities for decreasing the intraocular pressure: eye drops, laser trabeculoplasty, and surgeries. But medications are the first choice, probably, because it's well tolerated. You have various options. There is no acute complication. And at any point, you can switch to surgery or laser. But it has got its own demerits. It tends to become less effective with time, and you have to escalate your treatment. Long-term use of anti-glaucoma medication is an important risk factor for the failure of filtration surgery. It affects the quality of life, long-term cost, and compliance are other issues. So let's see, what do we have in the basket. We have PG analogs and beta blockers as the first line, alpha agonist and carbonic anhydrase inhibitors as the second line, and now we have the rho kinase inhibitors and our own all pilocarpine in the third line. So prostaglandin analogs are the first choice drug for primary open-angle glaucoma as of now. It decreases the intraocular pressure by 30 to 35%. It is superior to beta blockers. It has got a convenient once daily dosing, which helps in improving the compliance with the treatment. No major systemic side effect except for certain flu-like symptoms. No tachyphylaxis and long-term drift. Cost was an important limiting factor previously, but with the generics in the picture now, cost is no longer a limiting factor. So the mechanism of action of prostaglandin, it basically gets hydrolyzed into its active form and binds to the prostaglandin FP receptors and modifies the extracellular matrix of the ciliary muscle, increasing the uveoscleral outflow. You have the prostanoids, which are the latanoprost, tavoprost, tafluprost, and latanoprost and bunod. The prostamide is the bimetalprost. Tafluprost and latanoprost and bunod is not yet available in India. In primary and secondary open-angle glaucoma, prostaglandin analogs are the first choice drug. And primary angle closure glaucoma, they do work better after doing a laser peripheral iridotomy. And as we know, prostaglandin is an inflammatory mediator and has to be avoided in any inflammatory glaucoma such as neovascular glaucoma, uveitic glaucoma, and acute angle closure glaucoma. And in aphakics and patients with PC rent, you have to use it with caution as it can predispose to cystoid macular edema. The side effect profile include prostaglandin-associated periorbitopathy, cystoid macular edema, anterior uveitis, and reactivation of herpes simplex keratitis. In this era where we are talking about fillers and Botox, prostaglandin-associated periorbitopathy is a significant side effect which has to be explained to the patient. You have to convince the patient regarding the benefits of the treatment. The features include eyelitosis, orbital fat atrophy in ophthalmos, hyperpigmentation of the periorbital skin, etc. It is not an irreversible side effect. These features can get reverted after about 8 to 12 weeks of stopping the drug. And when you compare different prostaglandins in the group, studies tell that bimetalprost has got the highest efficacy and latanoprost has got the most favorable tolerability profile, but this is not a hard and fast rule. You start a prostaglandin for one patient, see whether it's working or not, then you can always switch to a second drug in the same group and see whether it's working. So our next group is beta blockers. So the basic mechanism of action is by decreasing the aqueous production by binding to the beta-2 receptors. You have the non-selective and the selective ones. The selective one is betoxolol, but it is less effective than timolol, which is a non-selective one. Despite being a first-line drug, decreasing the intraocular pressure by about 25 to 30%, what makes it a less favorite one for the glaucoma practitioners is its side effect profile and tachyphylaxis. You can have numerous systemic side effects like bradycardia, heart failure, pulmonary side effects like exacerbation of asthma, neurological side effects, masking hypoglycemic symptoms in diabetic patients. All these are the systemic side effects associated with the use of timolol. And the second thing is tachyphylaxis, that is loss of IOP lowering efficacy over time. It can either be a short-term escape or it can be long-term drift. Short-term escape can be due to either upregulation of the beta-adrenergic receptors, or it can be due to a change in the receptor sensitivity itself. In long-term drift, the drug may work for months or years. After that, you tend to lose its efficacy. It can either be due to drug tolerance, or it can be due to the progression of disease pathology itself, that is due to progression of trabecular meshwork outflow problems. So you have to avoid this drug in cardiogenic shock, decompensated cardiac failures, heart blocks, and reactive airway diseases like bronchial asthma and COPD. Alpha agonists do have a dual mechanism of action. They decreases the aqueous production and also increases the uveous scleral outflow. You have the non-selective and the selective ones. As of now, brimonidine is the only one which is available to us in the Indian market. Brimonidine is available in 3 concentration, 0.2, 0.15 and 0.1%. You are trying to decrease the concentration in order to decrease the side effect profile. The neuroprotective action of brimonidine is well established in animal studies, but when it's not clinically proven. And coming to the side effect, ocular allergy and follicular conjunctivitis is a notorious side effect of this group of drug. Epreclonidine, which was available to us in the early 2000s, has been withdrawn because of the side effect, which was reported in around 50% of the patients. With brimonidine, it is reported in around 20 to 30% of the patient. The patient may be using this drug for years. It's a delayed type of hypersensitivity reaction. Patient may be using this drug for years, and at a later point, patient comes with follicular conjunctivitis, which may be mistaken for viral conjunctivitis. But you have to stop this drug when patient comes with follicular conjunctivitis. And systemic side effect includes hypotension, drowsiness. So be careful while using this drug in drivers, elderly, and heavy machinery operators. It crosses the blood-brain barrier and causes CNS depression, so has to be avoided in children less than 6 years of age, preferably to be avoided in children less than 10 years of age. The next group of drug is the carbonic anhydrase inhibitor. You have dosolamide and brinzolamide as the topical agent, acetazolamide and methazolamide for the systemic use. Again, the mechanism of action is by decreasing the aqueous production by inhibiting the carbonic anhydrase enzyme. Dosolamide has got an acidic pH with a thrice daily dosing. Brinzolamide has got a neutral pH with a twice daily dosing, and it's a suspension, so has to be shaken well before use. Since it has got a neutral pH, brinzolamide is thought to be better tolerated than dosolamide. And another practical point is, please do avoid this drug in patients who have decompensated cornea and who are corneal graft recipients, as it can precipitate corneal edema. And side effects, when used topically, it can cause allergic reactions of the conjunctiva, superficial punctate keratitis, and metallic aftertaste. Systemic drug is acetazolamide. The dose is 250 milligrams 4 times a day. That is the maximum dose, but it has got a lot of systemic side effects. Elderly patients may find it very difficult to tolerate the drug. The side effects include paresthesias, hypokalemia, metabolic acidosis, renal stones, etc. Rho kinase inhibitors are the newest drug which is available to us. It has got a novel mechanism of action by improving the aqueous outflow. Rho kinase inhibitors, they alter the cell shape in the trabecular meshwork, allowing improved aqueous humor outflow. You have 2 molecules, one is netarsudil and the other one is ripasudil. Netarsudil, in addition to improving the aqueous outflow by blocking the norepinephrine transport inhibition, it reduces the aqueous humus production, and also it reduces the episcleral venous pressure. It has got a once daily dosing, and ripasudil has got a BD dosage. Finally, a word about pilocarpine. Even though it's an all drug, it works as a wonder drug in certain specific situations, particularly in pseudophakic with angle closure glaucoma, it may work. So to conclude, know your drug so that you can make a better choice for your patient. Thank you.